So this is chapter 34, recording 2, Anatomy and Physiology. The body is growing and changing rapidly during childhood. You must understand the physical differences between children and adults and alter your patient care accordingly. The respiratory system. Anatomy of pediatric airway differs greatly from that of adults. Pediatric airway is smaller in diameter and shorter in length. Lungs are smaller. The heart is higher in the child's chest. The glottic opening is higher and positioned more anteriorly, and the neck appears to be non-existent. As a child develops, the neck gets proportionally longer as the vocal cords and epiglottis achieve anatomically correct adult position. The occiput is larger and rounder, which requires more careful positioning of the airway. So the back of the head is much longer and more rounded. So in order to get the airway open, typically you have to put something under the shoulders to get the airway opened correctly. The tongue is larger in relative size of the mouth and more anterior location in the mouth, so a child's tongue can easily block the airway. There's a long, floppy U-shaped epiglottis in infants and toddlers that is larger than in adults. The rings of the cartilage in the trachea are less developed and may easily collapse if the neck is flexed or hyperextended. The upper airway has a narrowing funnel shape compared to the cylindrical shape of the lower airway. The diameter of the trachea in infants is about the same of a drinking straw. Airway is easily obstructed by secretions, blood, or swelling. Infants are nose breathers and may require suctioning and airway maintenance. The respiratory rate of 30 to 60 breaths per minute is normal for a newborn. A respiratory rate of 12 to 20 is normal for a teenager. Children have an oxygen demand that is about twice of an adult's. The higher demand combined with the smaller oxygen reserve increases the risk of hypoxia. The muscles of the diaphragm dictate the amount of oxygen a child inspires. Anything that places pressure on the abdomen of a younger child can block the movement of the diaphragm and cause respiratory compromise. Must use caution when applying straps of a spinal immobilization device because it may hinder the tidal volume or the amount of air that a child can get in. Gastric distension can interfere with movement of the diaphragm and lead to hypoventilation. So when you're ventilating a child with a BVM, you have to be careful so that you don't end up making it so that they can't breathe. Less air exchanged with each breath, so detection of poor air movement or complete absence of breath sounds may be more difficult. Breath sounds are more easily heard because of the thinner chest walls, though. The circulatory system. It's important to know the normal pulse ranges when evaluating children. An infant's heartbeat can beat 160 times more or more per minute. This is the primary method of the body uses to compensate for decreased perfusion. Children are able to compensate for decreased perfusion by constricting the blood vessels in the skin. So blood flow to the extremities can be diminished, leading to pale, cool, and clammy. So, and weak distal pulses as well. This is how they do really well at compensating. Here's a normal table of pulse rates for the different age groups. The nervous system. Compared to an adult, the nervous system is immature, underdeveloped, and not well protected. The head-to-body ratio of an infant or young child is disproportionately larger, which makes them more prone to head injuries from falls or motor vehicle crashes. The occipital region of the head is larger, which increases the momentum of the head during the fall. The subarachnoid space is relatively smaller, leaving less cushioning for the brain. The brain tissue and cerebral vasculature are fragile and prone to bleeding from shearing forces, such as during the incident of a shaken baby syndrome. Pediatric brain also requires a higher amount of cerebral blood flow, oxygen, and glucose than does adult brain tissue. This means that the pediatric brain is at risk for secondary brain damage from hypotension and hypoxic events. The spinal cord injuries are less common in pediatric patients, however. If the cervical spine is injured, it's more likely to be injured to the ligaments because of the fall, not to the actual brain itself or spinal cord itself. For suspected neck injury, perform manual inline stabilization or follow local protocols. The gastrointestinal system. Abdominal muscles are less developed in pediatric patients. This offers less protection from trauma. The liver, spleen, and kidneys are proportionally larger and sit more anteriorly, so they are more prone to bleeding and injury. Because organs are positioned closer to each other, there's a higher risk for multiple organ injury caused by minimal direct impact. The musculoskeletal system. Open growth plates allow bones to grow during childhood. As a result of open growth plates, children's bones are softer and more flexible, making them prone to stress fractures. Bone length discrepancies can occur if there's an injury to the growth plate. And it's important to immobilize extremities with sprains and strains because they may actually be stress fractures. The bones of the infant's head are flexible and soft. Soft spots are located in the front and back of the head, referred to as fontanelles, will close at a particular stage of development. Fontanelles of an infant can be a useful assessment tool. Bulging fontanelles can indicate increased intracranial pressure. Sunken fontanelles can indicate dehydration. The thoracic cage in children is highly elastic and pliable because it's primarily composed of cartilaginous connective tissue, and the ribs and vital organs are less protected by muscle and fat. The integumentary system. The integumentary system of the pediatric population differs in a few ways. The skin is thinner with less subcutaneous fat. Composition of the skin is thinner and tends to burn more deeply and easily than in adults. There's a higher ratio of body surface area to body mass, which can lead to larger fluid and heat losses. Patient assessment. Scene size up. Assessment begins at the time of the initial dispatch. Prepare mentally for approaching and treating an infant or a child. Plan for pediatric scene size up, pediatric equipment, and age-appropriate physical assessments. If possible, collect age and gender of the child, location of the scene, NOI or MOI, and the chief complaint from dispatch. Scene safety. Ensure appropriate safety precautions and standard precautions have been taken. Note the position in which the patient is found. Look for possible safety threats to the child, parents or caregivers, bystanders, or EMS providers. The patient may have a safety threat if they have an infectious disease, so keep that in mind. Next, do an environmental assessment. This will give important information on the chief complaint, number of patients, MOI or NOI, and ongoing health risks. Inspect the physical environment and interactions with caregivers and family. Information from parents or caregivers is important and may provide clues to the patient's problem. Document dangerous scene conditions and inappropriate statements from caregivers. A traumatic scene where the child is unresponsive or too young to communicate. Assume the injury was significant enough to cause head or neck injuries. Perform cervical spine immobilization if you suspect the MOI to be severe. Remember to pad under the child's head or shoulders, facilitate a neutral position for airway management. So you may have to place a roll underneath the shoulders so that that big old occiput is balanced out so that the airway remains open. Primary assessment. The objective of the primary assessment is to identify and treat immediate or potential life threats. We use the pediatric assessment triangle to determine if the patient is sick or not sick. The PAT, pediatric assessment triangle, is a structured assessment tool that allows you to rapidly form a general impression without touching the patient. It can be performed in less than 30 seconds. The pediatric assessment triangle consists of 3 elements and requires 0 equipment. So you're going to look at the appearance, the muscle tone, and mental status of the patient. You're going to look at the work of breathing, and you're going to look at the circulation to the skin. So how does the patient look? From the appearance, you're going to note the level of consciousness or interactiveness and muscle tone. You can also evaluate the pediatric patient's level of consciousness by using the AVPU scale, modified as necessary for the pediatric patient's age. An infant or child with a normal level of consciousness will act appropriately for his or her age, exhibiting good muscle tone and maintain good eye contact. Poor muscle tone or poor eye contact can mean an abnormal level of consciousness. The Tickles mnemonic can help determine if a patient is sick, so tone, interactiveness, consolability, look or gaze, and speech or cry. Work of breathing increases as the body attempts to compensate for abnormalities in oxygenation and ventilation. So an increased work of breathing often manifests as abnormal airway noise, accessory muscle use, retractions of the intercostal muscles or sternum, head bobbing, nasal flaring, tachypnea or an increased respiratory rate, and then the tripod position in older children. It may maximize the effectiveness of the airway. So you might actually see them sitting in the tripod position. Circulation to the skin. When cardiac output fails, the body shunts blood from areas of lesser needs, such as the skin, to areas of greater needs, such as the brain, heart, and kidneys. Pallor of the skin or paling of the skin and mucous membranes may be seen in compensated shock. May also be a sign of anemia or hypoxia. Mottling is another sign of poor perfusion. Cyanosis reflects a decreased level of oxygen in the blood. It's a very late sign of respiratory failure or shock. Never wait for the development of cyanosis before administering oxygen. From the PAT findings, you'll be able to decide if the pediatric patient is stable or requires urgent care. If the patient is unstable, assess the ABCs, treat any life threats, and transport immediately. With obvious life threats from external hemorrhage, assess and address the CAB first, including tourniquets for arterial hemorrhage from the extremities. If the patient is stable, continue with the remainder of the patient assessment process, perform necessary interventions, and discuss transport options with the parents or caregivers. Hands-on ABCs. This is the next thing that you'll perform. Assess and treat any life threats as you identify them by following the ABCDE format, so airway, breathing, circulation, disability, and exposure. For airway, if the airway is open and the patient can adequately keep it open, assess airway adequacy. If the patient is unresponsive or has a difficulty keeping the airway clear, ensure that it is properly positioned and it's clear of mucus, vomitus, blood, and foreign bodies. If trauma has been ruled out, use the head tilt chin lift to open the airway. If trauma is suspected, use the jaw thrust remover. Always position the airway in the neutral sniffing position. Keeps the trachea from kinking from being either hyperextended or hyperflexed. Maintains proper alignment. Should you have to immobilize the spine. Establish whether the patient can maintain his or her own airway. Breathing, look, listen, and feel technique is what we go to in order to assess breathing. Place both hands on the patient's chest to feel the rise and fall of the chest wall. Belly breathing in infants is considered adequate because of the soft, pliable bones of the chest and the strong muscular diaphragm. Bradypnea, or a decrease in respiratory rate, is an ominous sign and indicates impending respiratory arrest. Circulation must determine if the patient has a pulse, is bleeding, or is in shock. Infants and children can tolerate only a small amount of blood loss before circulatory compromise occurs. In infants, palpate the brachial pulse or femoral pulse. In children older than 1 year, palpate the carotid pulse. Strong central pulses usually indicate the child is not hypotensive. Weak or absent peripheral pulses indicate a decreased perfusion. The absence of a central pulse indicates the need for CPR. Tachycardia may be an early sign of hypoxia or shock, or a less serious condition such as fever, pain, and anxiety. Interpret the pulse with the context of the overall history, the PAT, and the primary assessment. A trend for increasing and decreasing pulse rate may suggest worsening hypoxia or shock or improvement after treatment. When hypoxia or shock becomes critical, bradycardia occurs. Bradycardia in a pediatric patient often indicates impending cardiopulmonary arrest. Feel the skin for the temperature and moisture and estimate the capillary refill time. Color should return within 2 seconds in pediatric patients. Disability, use the APU scale or the pediatric Glasgow Coma scale to assess the level of consciousness. Check the responsiveness of the pupils. A normal pupil will constrict after a light stimulus. Pupillary response may be abnormal in the presence of drugs, ongoing seizures, hypoxia, or brain injury. Look for symmetric movement of the extremities. Pain is present with most types of injuries. Inadequate treatment of pain may have adverse effects on the pediatric patient and the family. Assessment of pain must take into consideration the developmental age of the patient. The ability to recognize pain will improve as the patient becomes older, and you may need to use the Wong-Baker Faces scale in assessing the level of pain. We'll go ahead and stop right here.